So our first topic for today is sudden infant death syndrome. Sudden infant death syndrome is the commonest cause of death in the first year of life. It is most common at 3 months of age. So what we can do to reduce the risk of sudden infant death syndrome? The following advices should be given to the patient, parents. Put infants to sleep on their backs and not their front or sides. Avoid overheating by heavily wrapping infants. Blankets should not be higher than their shoulders. Infants should be placed with their feet at the foot of the cot. And avoid bringing baby into the bed after parents have consumed alcohol or sedative medications. Avoid sleeping with infant on sofa. Avoid using a pillow. Use sheets and blankets rather than a duvet. So these are the advices that we should give to the parents to decrease the risk of sudden infant death syndrome. Now, our next topic is cow's milk protein allergy. Cow's milk protein allergy is common in formula fed babies. Formula milk are made from cow's milk and its composition is changed so that it can just look like breast milk. So if uh, cow's milk protein allergy is common in infants who are on formula milk, and how an infant with cow milk allergy will present to us. Clinical feature of cow milk protein allergy include itching, erythema, urticaria, acute angioedema, colicky abdominal pain, vomiting, and diarrhea. There are two types of cow milk allergy. One is IgE mediated reaction and one is non-IgE mediated reaction. So how we can identify if it's IgE mediated reaction or if it is non-IgE mediated reaction. If the reaction is acute, that is if the baby develop these sign and symptom immediately after the feed, such as nausea, vomiting, colicky abdominal pain, pruritus, and erythema. If all these features appear after taking milk, suddenly after taking milk, then our diagnosis would be IgE mediated reaction. And if the symptom or these symptoms they are chronic, or there is a history of reflux, loose stools, not gaining weight, perianal redness, skin manifestation like erythema or atopic eczema, then we will say it's non-IgE mediated reaction. So cow milk allergy is divided into two types of reactions. One is immediate and the other one is chronic. In immediate, the parent will complain of nausea, vomiting, colicky abdominal pain, and pruritus, erythema, etc. While in non-IgE mediated reaction, there will be history of reflux or loose stools and not gaining weight and perianal redness, etc. So on the basis of these clinical features, you can differentiate between IgE mediated reaction and non-IgE mediated reaction. So in a STEM, look for the presenting symptoms in the exclusively formula fed baby. If the chief complaints are something like not gaining weight and constant reflex, then this will be non-IgE reaction. And the answer will be the treatment in both the cases would be changed to hypoallergic formula.
So in both cases, we change the formula to hypoallergenic formula
Yes,
in
yes,
IgE and non-IgE both.
yes. Because
Okay,
both are allergic reactions,
right.
and both are due to allergy to cow milk. So that's why we need to change to hypoallergic formula.
Okay.
Our next topic is reactive lymphadenopathy. Now, lymphadenopathy, reactive lymphadenopathy, it is commonly seen in children after an acute infection. And remember that whenever lymphadenopathy is due to infection, it will be tender or painful. So, if cervical lymphadenopathy is due to an acute reaction to infection or reactive lymphadenopathy, no further investigation is required. So, reactive lymphadenopathy that occurs after an infection in an otherwise well child, such as normal blood count, no weight loss, or no features of Kawasaki disease, then no further investigations are required. So, reactive lymphadenopathy in children can occur due to infections. What are the other causes of lymphadenopathy? Lymphadenopathy can also occur in hematological malignancies, viral infections such as CMV and Epstein-Barr virus and Kawasaki disease and tuberculosis. They all can cause. So the important causes that we need to know is that infection due to bacteria, viruses, and hematological malignancies. Now, when are we going to investigate lymphadenopathy? What is the criteria? What features should be present to do further investigation in case of lymphadenopathy? So red flags, these features, these are known as red flags of lymphadenopathy. So features of more than one of the following should prompt an urgent referral, especially if there are no signs of local infection. So more than one means at least two of these should be present to refer the patient for further investigation. So lymphadenopathy due to infection is tender or painful, while lymphadenopathy that is due to hematological malignancy is non-tender, and the lymph nodes in these cases are hard and firm lymph nodes, and these lymph nodes they progressively enlarge, and the size of lymph nodes are usually more than 2 centimeters. So any of these two features, if they are present in lymphadenopathy, then we need to refer the patient for further investigation. For example, a 15-year-old boy presents with a lump in his neck for a few months. He is asymptomatic with no fever, so no signs of infections are present. Night sweats or weight loss. On examination, firm non-tender lymphadenopathy is noted in the left cervical chain. What is the most appropriate investigation? So no signs of infection is present, but the child has a cervical lump in the neck. The most appropriate investigation in case of lymphadenopathy is that is due to causes other than infection is excisional biopsy. And the most appropriate initial investigation is complete blood count to see if there is any uh, anemia or decreased TLC or decreased platelet count. So excisional biopsy is the most appropriate investigation in case of lymphadenopathy that has red flags and with features of or with suspicions of a hematological malignancy. Another example is IV antibiotics followed by oral antibiotics. He has improved down and fit for discharge. Treating team has noticed there are enlarged cervical nodes of one of the lymph node is less than 2 centimeters, so it's not a red flag. his FBC are normal, his full blood count is also normal, just a slight increase in WBC, that is 11.5. What should be done? So in this case, we can see that the boy has a history of tonsillitis. So this lymphadenopathy is most likely due to infection. And if lymphadenopathy is due to infection and no red flags are present, then we do not need to do any further investigation. So the answer is reassure and continue to discharge him. It is normal to have reactive lymphadenopathy after an acute infection. Reassure as it would resolve in a few days. A slightly elevated WBC, we know that in hematological malignancies, WBC count is raised massively, mostly more than 100. But a slightly elevated WBCs are normal in post-infection state, and they would also return to normal within a few days. So when we need to worry about lymphadenopathy, if lymph nodes are firm and non-tender, if lymph nodes are hard, and if lymph nodes are progressively enlarging, and if lymph nodes are more than 2 centimeters in size. So a lymph node that is increasing in size and is 2 centimeters or more than 2 centimeters should be a worry, even if no other suspicious features such as fever and low weight loss are present. The most appropriate initial step is to do a full blood count, and the most appropriate investigation in case of lymphadenopathy is excisional biopsy. Enlarged lymph nodes can be caused by viral infections such as CMV, Epstein-Barr virus. It can be caused by hematological malignancies such as lymphoma and ALL. It can be caused by Kawasaki disease, and it can be caused by tuberculosis. Now our next topic is lateral neck masses. Lateral neck masses, there are two important lateral neck masses that can be present in children. One is branchial cyst and the other is lymphangioma or cystic hygroma. So the one feature on the basis of which we can differentiate between these two lateral neck masses is transillumination. If transillumination is positive, or if the mass is translucent, then our diagnosis will be lymphangioma or cystic hygroma. And if transillumination is negative, or the mass is non-translucent, or the mass is opaque, then our diagnosis will be branchial cyst. So on the basis of transillumination, we can differentiate between cystic hygroma and branchial cyst. Now, there are two important frontal neck swelling. One is goiter and the other one is thyroglossal cyst. How we can differentiate between thyroglossal cyst and goiter? We can differentiate it on the basis of its movement with the movement of tongue. Thyroglossal cyst is, as its name indicates, it is a swelling that is attached to the tongue, to the base of the tongue. That's why it is known as thyroglossal cyst. Glossal means tongue. So a frontal neck swelling that moves upward with protrusion of tongue will be thyroglossal cyst. And if it does not move with protrusion of tongue, then it will be goiter. Remember that thyroglossal cyst and goiter, both of them moves upward with deglutition, while thyroglossal cyst moves upward with protrusion of tongue as well. of them moves upward with deglutition. This is common to both of them. The difference between them is that thyroglossal cyst, because it is attached to the base of the tongue, so it moves with protrusion of tongue as well. So that's how you can differentiate between these two frontal neck swelling, that is goiter and thyroglossal cyst. The most appropriate investigation in case of this frontal neck swelling is ultrasound. And if suspicious, then FNAC can also be done. Thyroglossal cyst is the commonest neck congenital anomaly. It may become painful if it's infected. The thyroglossal cyst moves up with tongue protrusion because it is attached to the thyroglossal tract, which attaches to the larynx by the pretracheal fascia. A neck midline lump that moves up with swallowing, goiter, or thyroglossal cyst, and a swelling that moves upward with the protrusion of tongue with thyroglossal cyst. Now, some points about CMV infection, cytomegalovirus infection during pregnancy. A 30-year-old woman who had a primary infection of cytomegalovirus during pregnancy gave birth 3 days back. The baby is asymptomatic. What is the most common complication that can occur in this child? So if a female gets cytomegalovirus during pregnancy, then the baby is at risk of getting sensorineural hearing loss. Congenital CMV is the leading non-genetic cause of sensorineural hearing loss in children. So in the question, they ask what is the most common complication that can occur in the child who is born to a CMV infective mother, then hearing loss will be your answer. Because hearing loss, congenital CMV is the leading cause of non-genetic sensorineural hearing loss. Other features that can be present in a cytomegalovirus infection other than sensorineural hearing loss is retinitis, mental retardation, microcephaly, seizure, and cerebral palsy. But the most common sequel following congenital CMV infection is SNHL, that is sensorineural hearing loss. For example, in asymptomatic child with cytomegalovirus infection, his mother wants to know the long-term complication. So the long-term complication in this case is hearing loss. So blindness, microcephaly, and seizure can also occur, but the most common one is hearing loss.
So if in the question they give all these hints of blindness and everything, so we should pick the hearing loss.
Yes, hearing loss is the most common. Others are less common or rare.
So if there is no option for hearing loss, then what would be the next answer?
If in the question they ask the most common complication of CMV, then hearing loss should be given as in the option.
Right.
Because this is the basis of the questions. The most common is always hearing loss. The
This
frequency of others is,
November exam. This was the question in November exam.
yes.
Yeah.
So there is no second most common or third most common. So they are not going to ask you without giving the option of hearing loss in the option. Next topic is neonatal conjunctivitis. The neonatal conjunctivitis is also known as ophthalmia neonatorum. ophthalmia neonatorum is conjunctivitis that is occurring in first 28 days of life. So whenever you see a case of ophthalmia neonatorum, you need to refer the patient to a secondary care for further assessment, for example, for culture of the discharge and for treatment. So what are the signs and symptoms of ophthalmia neonatorum? Fluid discharge plus swelling and redness of conjunctiva. In secondary care, culture of the discharge is done, and if the causative organism is chlamydia, then erythromycin is given orally, and if the causative organism is gonorrhea, then ceftriaxone is given IV. So for ophthalmia neonatorum due to chlamydia, erythromycin, oral erythromycin, and ophthalmia neonatorum due to gonorrhea, IV ceftriaxone. For example, a 2-week baby presents with fluid discharge from his eyes. He has red eyes. So fluid discharge with red eyes will refer the patient to secondary care immediately. Another example, a 5-year-old baby is brought by his mother. He has left eye discharge sticky for 5 days, no eye redness or eyelid swelling. So there's eye discharge that is sticky, but there is no redness or swelling. So it is not ophthalmia neonatorum. In ophthalmia neonatorum, fluid discharge with red eyes or lid swelling, they should be present. So in this case, we'll only reassure because the cause of this discharge is likely blocked nasolacrimal duct. The commonest reason for eye discharge in babies who are less than 12 months old, and simple massaging of the duct may help. So the commonest cause of discharge is blocked nasolacrimal duct, while infective causes of the discharge and redness and swelling is ophthalmia neonatorum that can be caused by chlamydia or gonorrhea. So if a child present to you with fluid discharge plus redness or eyelid swelling, then you will refer him to secondary care. And if there's only a discharge that is sticky, there is no redness or swelling, then you will reassure the patient because the cause may be nasolacrimal duct obstruction. Now, the next topic is maintenance fluid replacement. How to calculate maintenance fluid? To calculate maintenance fluid, we have a formula of 100, 50, and 20. 100 ml per kg for the first 10 kg, 50 ml per kg for the next 10 kg, and 20 ml per kg for remaining kgs. And after calculating this maintenance fluid, we need to divide it by 24 to calculate the fluid requirement in 1 hour. Or for hourly rate, we need to divide the fluid by 24. And we'll replace the fluid in 24 hours unless in hypernatremia. In hypernatremia, fluid will be replaced over 48 hours. Because if hypernatremia is corrected rapidly, it can lead to brain damage. Now the total fluid, this was the formula for maintenance fluid. Now if someone present to us with dehydration, then the total fluid that we need to give is 50 ml per kg plus maintenance fluid. So 50 ml per kg fluid is given to correct the dehydration plus maintenance fluid will be given to maintain this fluid balance. Of or red flags of shock are present. He has tachycardia, tachypnea, IV fluids, or if there is continuous vomiting, then we'll give IV fluids. In all other circumstances, we will rehydrate with oral fluids. Oral fluids is given in the form of ORS, oral rehydration solution, which contain both sodium and glucose. For maintenance fluid, sodium chloride 0.9% with glucose 5% or dextrose saline is used. And again, the fluid will be given in the form of 50 ml per kg plus maintenance fluids. And how we calculate maintenance fluids? 100, 50, 20. 100 ml for first 10 kg, 50 ml for next 10 kg, and 20 ml for remaining kgs. And remember that in addition to these fluids, if the patient is in shock, then we need to give a 20 ml per kg bolus of sodium chloride. Normally, if a patient presents with dehydration, this much fluid we need to give. That is 50 ml per kg plus maintenance fluid. But if the patient is in shock, then we will give 20 ml per kg bolus of sodium chloride. And instead of 50 ml per kg, we need to give 100 ml per kg in addition to maintenance fluids. So in case of shock, extra fluid will be given in the form of 20 ml per kg bolus of sodium chloride and then 100 ml per kg in addition to maintenance fluid. Let's do an example. A 32 kg child who is dehydrated requires intravenous fluid replacement. What is the total volume of fluid required and the rate per hour? So the child is dehydrated. The total fluid that he need to receive is 50 ml per kg plus maintenance fluid. So 32 kg multiplied by 50. 32 kg multiplied by 50 is 1600 ml. Because 50 ml per kg be multiplied with 32, that is 1600 ml. Now let's calculate maintenance fluid. The child weight is 32 kg. For the first 10 kgs, 100 ml per kg. So 10 multiplied by 100, 1000 ml. For the next 10 kg, 50 ml multiplied by 10, 500 ml. And for the remaining kgs, that is 12 kg. So maintenance fluid is 1740 ml. And to correct dehydration, the fluid is 1600 ml. And the total fluid is 3340 ml. We'll divide this fluid with 24, 3340 ml over 24 to calculate hourly rate. So after dividing it over 24, this is the answer we have got. That is 140 ml per hour. This is how we calculate the total fluid and hourly rate. This is when.
Can you please explain that again, because I'm not getting it? So the
So a
difference
30,
between the dehydration
yes,
and maintenance fluids, what is the difference between them?
if someone loses a certain amount of fluid, then we need to give that fluid, replace that fluid. That is to correct the dehydration. For example, if someone has lost 1000 ml, then we need to replace that fluid. And after replacing the fluid, we need to maintain that fluid balance. So that's why, along with the 50 ml per kg, we need to give maintenance fluid as well.
Right.
So to do that, to correct dehydration, we will calculate 50 ml per kg
Right.
and multiply it with, as the child weight is 32 kg, so multiply 32 with 50, and our answer is 1600 ml.
Right.
So this is, you can say, this is a replacement fluid. Now maintenance fluid will be calculated through this formula, that is 100, 50 and 20. 100 ml for first 10 kg, 50 ml for next 10 kg, and 20 ml for the remaining kgs. So the weight of the child here is 32 kg. For first 10 kg, we'll multiply with 100, that is 1000 ml. For the next 10 kg, the fluid is 500 ml, and for the remaining kgs, that is 12 kg, the fluid is 240 ml.
Right.
So replacement fluid is 1600 ml and maintenance fluid is 1740 ml, and the total fluid is 3340 ml. And to calculate the hourly rate, we'll divide it with 24.
Right.
Is it clear now?
Yes, it is.
So this is the scenario when the child will be dehydrated.
Right.
Now, if the child is in the shock, then our calculation will be different. If the child is in shock, then instead of 50 ml per kg, we need to give 100 ml per kg replacement fluid.
Right.
One difference is that, and the other difference is that we need to give a bolus of isotonic normal saline in the form of 20 ml per kg, in addition to this replacement plus maintenance fluid.
Right.
Is this point clear?
Yes, it is.
20 ml in the form of bolus, 20 ml per kg, and 100 ml per kg, not 50 ml uh, for replacement fluid.
So this the 100 ml per kg fluid, that will be extra added on top of what we are giving, like 3340 ml for 24 hours. If the child is dehydrated.
No, that 100 ml will replace here. Instead of
Okay.
50 ml, we'll give 100 ml per kg.
Right. So if the
To
child is
correct
in shock.
dehydration, yes. If signs of shock such as lethargy, tachycardia, decreased skin turgor, increased capillary refill time,
Right.
sunken eyes, if these signs are present, then we need to follow the protocol of shock.
Right. And then we add 20 mil extra bolus. That will be
Yes, 20 ml extra bolus will be given. And also, instead of 50 ml, 100 ml per kg fluid will be given. Maintenance fluid will be same in all the cases.
Okay. Got it. Thank you.
Now, an 8-month-old baby presents with sunken eyes and tachycardia. He has not drunk any milk since yesterday. His weight is 8 kg. What is the required IV normal saline bolus? So what is the bolus that should be given to this baby? Because the baby has signs of shock, so he need to receive an IV bolus of normal saline initially.
So 20
how much? Yes.
per kg, 8 to 160 ml.
Yes, 160 ml bolus of normal saline should be given. Because they have asked about only the bolus, So the answer is 160 ml.
Right.
You can calculate the maintenance and replacement fluid as well. What will be the replacement fluid?
Replacement fluid would be 8 multiplied by 50. So but this is baby is in shock, so it will be 8 multiplied by 100, 800.
Yes, 800 ml is replacement fluid. And what about maintenance fluid?
So that will be so that's like in the so it's less than 10 kg, so it should be 50 ml in the
So the
for the
first 10
first
kg,
10
first 10
kg,
kg will always be multiplied by 100.
100, yeah, so it will be 800.
Yes, 800 ml maintenance, 800 ml replacement. The total fluid is 1600 ml over a period of 24 hours.
per ounce.
Similarly, another example is a child who weighs 33 kg. Now, signs of shock include feeble pulse, tachycardia, hypotension, lethargy, dry mucous membrane, and low urine output. So if a child with diarrhea presents to you with these signs and they ask you about the most important initial investigation, then your answer should be urea and electrolyte, because the first organ that is affected by shock is kidney. So that's why if someone presents to you with signs of shock, then the most important initial investigation is to check his urea and electrolyte imbalance. Some more signs of dehydration: decreased urine output is also a sign of dehydration. Decreased skin turgor, increased heart rate, sunken eyes, etc. Again, fluid will be replaced orally if no signs of shock are present and the child can tolerate already. Otherwise, we'll need to admit the patient and give IV fluids. And if there is associated hypokalemia, then potassium chloride should also be added to normal saline to correct the hypovolemia as well as